Can you hear us, Dr. Igarashi? No, we can't. We still can't hear you. We still can't hear you. A moment, please.
Okay.
Yes, we can hear you now. Good evening, Dr. Igarashi.
Yes.
Yes. Good evening. Good afternoon.
Yes, we can hear you.
Thank you very much for your invitation for this meeting. We are waiting so long time.
Yes.
So I want to start this procedure.
Yes, please.
Okay. Please explain briefly this patient introvert.
Very briefly, I will try to explain the patient. He is a 47-year-old gentleman who's a diabetic hypertensive, and he presented to us in the last month with a history of exertional anemia. His high sensitive proteins were elevated, echo was normal, and renal parameters was normal. So with this, in ECG was also normal. So we did proper height. We performed an angiogram for him, which shows a significant tubulosis. Next slide, please. And then the left wave was normal. LED, there was a total fluid after the diagram. And there was a distal LED retrograde from the right coronary artery. Left circumflex has got a long calcified region with a thrombus. And then the right coronary artery is dominant, and distal right, the PDA, he has got a 90% region. So we had calculated the CSAT score and the JCTO score, and the case has been discussed at the RT meeting, and then it was the surgeon suggested us to go for an angioplasty because the LED is diffuse and it is small in candidate. So because of these reasons, initially we did the angioplasty of the left circumflex with 2 stents and also the PDA with 1 stent, and then we left this complex LED to Professor Igarashi, and then we welcome him to this case. Thank you.
Okay, I want to show you today's angiogram. Okay. Please show.
Can you show the angiogram from the beginning?
Yeah. This is very promising.
No, we can't see the angiogram. Okay.
From RCA.
No. Can we go to the angiogram right screen, please? No. Yes, this is the screen.
Yes. Okay, see?
Yes, we can see.
A simultaneous exhibition image. Yes. From RC Vista PD branch, very promising intervention tracheal is detected like this. And this is the APD tracheal. Can you see? CCO is mid LED. And spotting calcium is detected on fluoroscopy. Can you see?
Can you see the calcium there in the mid LED?
Yes.
Calcium in the mid LED.
Yes, we can see.
With the large extent of calcium in the diffuse in the LED.
And LED CTO division is not so long. However, this CTO is entry point is very ambiguous, and the distant target is very poor. So short, however, it's not so easy to treat by antigrade approach, I think.
Yes.
And so maybe in this case, lateral approach is necessary. Unfortunately, very promising product is detected from RCA like this. Okay. However, anyway, this is a de novo case, and usually start with antigrade. That is the usual style. And to confirm first entry point, in this situation, IVAS is very useful device. Yes. And before IVAS examination, our impression of entry point is can you see the portion of CCO calcium is detected, and before entry point there is a diagonal branch, and after verification of that diagonal branch, there's a branch is detected. And the branch, proximal part, a small branch is detected. Our impression is just proximal, this is the branch. And probably smoothly, this line is almost straight to this target CTO region. That is our first impression.
Yeah.
Yes, we understand that at the point of entry of the CTO, you have concerns of calcium there. So we do understand, yes. Go ahead.
Apart from that, what he says is that beyond the diagonal and at the level of the sector, he thought that the LED was arising on the opposite side of the sector. And the small branch is the branch of the sector. That was what we would presume. And with this impression, he started the intravascular also.
Okay.
Next one.
Next one, please.
Okay, I have selected proximal vector branch like this. And the next one. Okay, I think I was fine. Okay, and then please show me the next one. Next one. Next one. Okay, this is working. By checking, I was finding, I detected right side, small zester branch branches, main vessel,
Oh.
Once he had put the wire and intravascular probe in the first sector, he found the LED is there just on the outer side of the sector, which he thought was the branch of the sector, but in fact it is the main LED. Can we use intravascular process?
So before you put in the IVUS probe, we were not able to see that branch. Why do you think we are looking, doesn't it look a little different?
Oh, maybe the angiogram is same, but maybe he says that there was a route on the angiogram, and there was route is into the LED main branch. So I want to see if possible the IVUS image. Do you have IVUS image of the entrance of the CTO?
Raghu, can you show us the IVUS?
Yes, sir. Oh, we are going to show you now, right?
Okay, this is the entry point of this LED.
This is the entry point of the LED. We have a neon blue wire in the entry point of the LED.
And I will show you soon
The IVUS.
I have an image. This is 8 print system.
So we went with the 8-print system for the retrograde powder level, and for the ICSI level, we went with the 7-print system.
So Raghu, we still have to discuss on the IVUS. Can you explain the IVUS?
Pardon? Go ahead.
Can you tell us the IVUS findings?
Pardon?
Can you tell us the IVUS findings?
Okay, and then you set the branch.
Can you get the audio, please?
Yeah, we can hear you. Can you describe the IVUS? So yes, we see the wire now. Yes.
Can you see the IVUS as a big one on the screen, IVUS big on the screen?
Yes, we see that.
I cannot able to see the audio. So you can see the IVUS feedback from the sector.
Yes,
Yeah.
Yes.
this is second level.
Yes.
That is main course of LED.
Ah, okay, understand.
Yes. Yes.
Can you get the audio, please? Can you get the audio, please?
This is diagonal. I cannot hear.
Yeah, we completely understand that is the entrance of the CTO. Yeah, from the angiogram, maybe that is this a septal channel, but this is the entrance of the LED.
And please show you live image again. Yes. Please show me image.
What happened?
Video.
Raghu, can you go back to the fluoro image and remove the IVUS from there? Because we can't see anything on IVUS anyway.
Yeah. So we reduce it. So we produce the IVUS or no?
Okay. So with what wire are you probing now?
Please show IVUS image again.
And we were probing with a cyan blue.
Cyan blue over a microcatheter?
Yes, it's a phosphide.
Okay.
Cyan blue or a phosphide. But the point of interest is the intravascular ultrasound imaging for the antegrade tract to show the, you can see here, Professor Vigrani.
Yes, one of the direction is still blue, and that kind of wire is advanced to light side.
So you can So you can see at 1 o'clock and 2 o'clock is cyan blue, which is the element.
So their actual SS forces is very different from past impression.
Yeah. The vessel close is completely different. So now we go with another wire, Gaia second, with the antegrade tract to penetrate and try to make an entry from the antegrade.
So you are going to fix your IVUS image at one spot and IVUS guiding penetration you will do now? Raghu, the IVUS is...
So we have only the offset.
IVUS is inside the catheter.
IVUS is away from the lesion. So we are going to penetrate using the phosphide as a marker to which we exchange the cyan blue with the Gaia second.
In this situation, IVUS guided penetration is possible because the branch is too proximal.
Yeah. So we change the monitor, the full images to the main image.
Okay, can you go in and make capture the message? Or go to the main screen?
Right. So you don't want to put the IVUS now?
No, yes, because just now the distance was foul, so they can't observe the
And calcium is alpha side.
So Dr. Okamura is sharing an important point. He has pulled the IVUS back into the guiding catheter because at the point of penetration, there is a lot of crowding. By putting in an IVUS, it's not going to help us there. Am I correct?
Yes. Because the tip of the wire is far away from the IVUS observation, because that is a very angulated septal. So that's why just now IVUS isn't needed.
So in which situation you would use an IVUS?
Yeah, this situation. Maybe when I find the entrance of the CTO, maybe I also use the IVUS. But after that, the wire is going into the distal part around the 5 millimeter, so the IVUS cannot be seen it.
Right.
So that's why I will pull out the IVUS because a little bit messy. So just now, Dr. Igarashi, what kind of the wire are you using? A Gaia second. So, this is Atsunori Okamura. Usually, I want to use the XTR first, then Gaia second. Is there some reason of the skip the XTR? Okay.
Already, before live transmission.
Okay.
Okay, switch to the LF carrier. I particularly agree with your opinion.
Yeah, wire position is a very nice position.
SPR or such a kind of live wire should be dry. However, already almost dry. So, take a picture now. We have not understood. Why did he use Gaia? Okay, all right. Ready?
Maybe they
Okay.
think that the plug is high.
Almost inside of the vessel. However, from this view, it's a little bit diagonal branch side, I think. Yes. Okay. Anyway, I will push. Okay, back to the
Yeah, the tip position of the wire is very nice, but maybe the tip load is relatively lower compared to the distal exit point.
Any questions, comments from the commentators?
Yeah, I was just thinking that when it came to us as a hind thought that the IVS is not going to be useful and that the septal is arising early or there would be a lot of crowding. What if at the first, when we were planning, I thought that there was a one single septal which bifurcates and then there is a CTO. We could have thought of straight away going with a crusade, a double lumen catheter, put it in the septal and then try something with an XTR or Gaia 2 or 3.
See, he already got the point of entry. When he put an IVAS, the wire is all, you can already see the wire in the diagonal.
Yep.
Since you can already see the wire in the diagonal, there is no further role of IVAS there.
Yeah.
Sorry, wire in the LED. You're already seeing the wire in the LED on IVAS. The point of entry is correct. So now you can't, there is no need for IVAS. You already entered the correct spot. So you pull back the IVAS because you need area to play.
Yeah.
My question, my point of contention was after doing the IVAS and he saw one septal vessel, how confident you are that that is the LED and not the septal which we were contemplating by looking at the angiogram? How does one differentiate LED and any artery, true lumen?
His question is, how are you sure that particular thing is LED and not septal, not a small septal on an IVAS? When you put an IVAS in the septal, how are you sure that it is LED and not any other branch?
Yeah, because of the IVAS information, around the septal channel, there was the lumen. So that is LED. So only the branch of the from the IVAS image is septal, because this means that this is LED. No another LED.
My question is, by looking at the angiogram, you could see a small vessel adjoining that septal. By looking at the angiogram, there was a vessel. We thought it is a septal. After doing IVAS, we realized that this is the LED and not the septal, and we started probing that artery. Why can't it be another branch of septal, and how can you confirm that it is the LED but not any other vessel?
This is septal. Yes, yes. Initially they thought this is LED, but this turned out to be LED. On an IVAS, why are you saying this is LED and not septal?
So maybe the entrance is LED, and but also from the angiogram, the route is there is a calcification. So the wire route is going into the LED after insertion of the septal branch. If the wire route is going to down, maybe that is a septal, second septal. But the wire route is going to the just under the calcification LED side. So that's why he confirms that the wire is going into the LED side. Okay, thank you.
Another point, because we thought on the endovascular ultrasound, you can see an LED between 2 o'clock and 5 p.m., between 2 and 5. LED, I was fine. I was, you can see the LED between 2 and 5, 1 to 5. So if the vessel is between 1 to 5 on the IVAS, he says it is LED. That is one way he says that we can separate the LED from the septal. And septal happens around 9 o'clock or what?
Septal cannot be between 1 and 5, Raghu. Septal,
No, LED you see between 1 and 5. Septal, Professor Egrati, between 3, around 9 o'clock location, the septal location on IVAS.
Okay, please show me again.
Can you show, I will today show you this IVAS findings and other Dr. Egrati will be able to explain it.
I think already I explained.
But I think they were not able to understand.
Okay, just a moment. I want to pass through CTO region and I want to advance this property wire until it's a part of CTO region. Okay. After that, I will explain.
So exchange the guy with the copy wire.
Yes.
Yeah.
So Dr. Igarashi, since you made a progress, let us, you continue working, we will just visit the other lab and come back to you.
Okay, fine.
Switch to the other lab. Dr. Nagamatsu, Dr. Kapardi, no audio. Can you hear us? Dr. Kapardi?
Dr. Nagamatsu, can you hear us?
Hello? Kapardi? Kapardi, can you hear us? Dr. Nagamatsu?
And what kind of next time we are on the other? Thank you.
आप लोग पहले चेक नहीं करते हो क्या? पहले चेक नहीं करते हो क्या? Okay, can you hear us, Dr. Nagamatsu? Hello? Dr. Nagamatsu? Can you hear us? Hi, good evening. So can you take us through your case and what you have done till now? Can you please give us a summary and so that we can follow your case?
Presented with angina, class 2, and just showing abuse of ischemia. And an angio was done, which is showing residuals of disease. Can I show the angio? Yes. And a regulatory function. Please. Angio can you show? And then can you see this angio? No, first not to show the diagnostic, then
Okay, sure, show this one. But we can see there. Actually,
no, not this one. Previous recorded. Previous recorded. Previous recorded.
Change the previous one.
Yeah.
Uh-huh.
You are showing?
So I write that one as procedure.
Outside.
Kapardi, you want to describe the angio?
Hello.
Would you like to?
I want to tell the angio, I want to show the angiographic images. Patient having a segment ready CDO with the diagonal rising, and it is looking like a blunt proximal cap, except a doubtful nipple in elevocranial tooth.
Show me now.
Are you seeing that image?
Yes,
Yes,
can you
yes.
take us to the next image?
Okay.
Okay, and so this image is not diagnostic.
You are seeing the violet angio?
Yes, we can see.
Dr. Ganesh?
Yes, we can see that.
Okay.
Can you take us to the next image?
Yes. All right. Then we are next. Okay, we are next.
Okay, so I explain this. Alright, and this is to bring antibody. Firstly, I need bilateral injection. And we ordered insertion of the second frame, the CS, both sides from the femoral. And the antibody catheter is EB3.5. And I make a cycle by myself. And for the RCA is I choose the AA1.
Okay.
And I already make a part of the CTO, okay?
Yes, yes.
Yes, go ahead.
And we can see the CTO edit part of the enter. And the big problem is CTO digital part is a very big bifurcation. And with the diagram, can you see that?
Yes, yes, we can see it.
Bifurcation, that's bifurcation.
Yes.
Okay. And from the electronic view, we can see a little bit nipple. So this nipple is and the correct one I don't know, we don't know. So anyway, it looks like a brown type. And the next is a little bit over 20, and there is not the calcification, and a little bit bedding. So this time I share about this time is their single agent CKPCI case. And this is a score is 2 to 3.
So what's,
Okay. And it's a very complex character channel. So I injected the checking for the sensor channel from RCFD. This is I40 code 15, and this is my favorite view. And as you can see, we can see the some quarter, but not so good. And can you see that?
Yes, yes.
Another quarter here, RB. Very complex. And how about RC stickers like this, and include very good part. And like this. Okay. So how about the procedure?
so your primary strategy,
How they started?
Dr. Nagamatsu, your primary strategy is going to be retrograde. Why is that so?
Later, sure.
Can you tell us why you want to go retrograde?
I would like to keep. Okay, so I would like to keep this D very big bifurcation.
Come again?
The distal part of the bifurcation, maybe he wanted to keep from the antegrade approach, maybe some subintimal space where the hematoma will cause that part of the bifurcation. So that's why he wanted to firstly try to do from the retrograde to keep the bifurcation site.
So the distal exit point of the CTO is a bifurcation. So is that one of the reason he wants to go
Yes.
retrograde?
Yes, yes.
Dr. Okamura, what would you do?
I also easily switch to the retrograde approach, but for me, usually antegrade approach, just one try or 1-2 try, within the 15 minutes or 30 minutes, then we will move to the retrograde approach to keep the bifurcation site. But it depends on the doctors.
Okay.
So how about you?
I would go antegrade first. I mean, if I'm not able to find the area where to probe, I would perhaps put an IVUS in the side branch there.
Yeah, yes,
and
yes.
it looks very promising nipple there actually at the point of entry.
Yes, yes.
Yes.
Aeriocranial, there is a nipple that Nagamatsu told us. So, yeah.
Okay, anyway, go ahead.
Actually, this time is the second attempt. Yeah, okay. But this time is the second attempt. So I worry about already created some stage from anti-gravity. And for the keeping this bifurcation, the best way for me is retrograde.
Right. Actually, we don't mind watching a retrograde because we watched a lot of RCAs today. So this will be a good variation for us to see a retrograde from RCA into the LED.
Yes.
Okay. All right. And but we have a very long story and up to the current situation. And firstly, I tried to do the most proximal one. So I inserted the most proximal one to the this is Corsair 150.
Dr. Nagamatsu, Dr. Nagamatsu, there are a lot of beginners in the audience. Can you go step by step and tell us what wire did you use to enter into the channel and how you're taking the injection? Just tell us the basics. Because we believe that going from the RCA to LED is a little more difficult compared to the other way around. So please tell us step by step.
Okay, sure. Okay, I'm sure that this is RF40 and code 15. This is the key and the key film. Yes. And we can see some further channel are there. And the most upper one is the most professional one, PD. And it seems like the most professional one is the most straight morphology and compared with another one. So that's why I tried to the first one.
Okay, we agree.
Yeah, I agree.
And so and so I tried to using this one. And I searched the microplastic for the 150.
So what,
And confirmation the morphology again using a tip injection.
what was the first wire? Was it Xion with which you entered into the...
Yes, sure. Yes,
Okay.
Sure. Yes, sure. Yeah. And like step by step, so get advanced to the zero wire and changing the angiogram. So actually, this due to this vessel include the many parts like this. And but we're lucky that this zero wire get advanced to the NLAB like this.
So you didn't change the Xion wire, only just one Xion. You didn't change the Xion wire into the new one, only just one Xion.
So it was all through and through Xion. Kapardi, what did he use? It is a Xion wire?
Yes.
Okay.
Zero wire.
Okay.
But here find difficulties.
Yeah, and so I try to research on the more, I took the diagonal branch and this wire and for the getting the more good support. So that's why I said it's difficult to get the advance to this for the microplastic 150. Very, very difficult. And I waste time about 20 minutes around. And get advance to the here. But impossible more get advanced.
So did you predict that before that you will face... Dr. Nagamatsu, did you predict that you will have difficulty in tracking this Corsair? Did you predict? Because it looked quite straight to us.
Yes, actually. Yeah, it looks like okay, but actually very difficult. Okay, so I will show the data picture. And after, so finally, and I moved to another channel. Okay, I show the picture. And okay, this I moved to the more distant one.
Oh,
So he changed it.
yeah, but usually if you change the carnival or usually Dr. Nagamatsu, I'm Matsunori Okamura, usually if it is difficult to pass through the Corsair, maybe it's another microcatheter or OTW balloon, is maybe the usual thinking why you changed it. Why? Oh.
And so I think this microplastic, but I was very big friction, quite big friction. And so I think this is apparatus guidance.
You don't already have the fine cross. Fine cross longer one is also very promising. You don't have the fine cross. 150. You have, but you changed. You changed. Maybe some reason. Okay.
So before changing to the next septal, you would have used a fine cross?
Yes, it's better. It's better.
Yeah.
Yeah. If there is a cannabel, there isn't cannabel. Maybe it's a fine cross is a possibility. Or 1.25 OTW balloon thermo.
Any balloon? OTW?
OTW 1.25 thermo using is my favorite one.
What do you do at the point of resistance? You give a low inflation?
Yes, 2 or 3 atmosphere low for dilatation. After that, maybe another Corsair usually can be passed through it.
I see. So what Dr. Okamura is saying is, he tried for 20 minutes to take the Corsair, and if the Corsair doesn't go, he is actually going for another septal channel, but he would have used a 1.25 over the wire balloon and would have inflated at 2 to 3 atmospheres for some time at the point where he was getting resistance, And then you would have taken another course here. A new course here?
Yeah, new Corsair.
Okay.
Yeah. Maybe you can pass through it. Or there is a possibility of the flying course. But Dr. Nagamatsu is thinking the another thing, so that's why he changed it.
Because this septal channel looks more difficult.
Yeah.
Another one. So I have a very quite big friction. Okay. And I will show you the picture from the lighting. Can you see the proportion?
Oh. Okay. There is a hematoma. Okay. Aneurysmal formation.
Okay, so it might be that this, yes, and it might be this perforation. And actually connected to the ventricular chamber. It's okay, we can make this. But this picture shows, and the first sector branch and the first negotiated branch is quite big friction. It might be killed by this picture.
Yeah. But you told me that there is a leak, so it is okay. Yeah, it is okay. The first septal. Maybe, Dr. Nagamatsu, this perforation is caused by the first septal, so first attempt septal. This perforation is caused as the first one. Okay. Maybe it shifted or something. I don't know, but maybe, yeah.
Why do you think he had a perforation?
Maybe aggressive pushing of the corsair. Aggressive pushing of corsair, sometimes the corsair shaft is shifted to the apical side. So that's why that perforation will be made. Maybe I think that, this is aggressive pushing of the corsair.
Okay.
Ganesh, when you see a channel perforation, when does it become a concern to you? Like any coronary perforation? Would you at this point of time, because there are learners, as you said, tell them to do an echo to see if there is any tamponade, even if there is a channel perforation?
Even though it's a septal channel, would you call for an echo? Would you do an echo?
Echo is not needed. Echo is not needed. Maybe after a procedure, it is better to check it. But there is a leakage to the ventricular, so maybe it's no growing up. No echo.
After the procedure, he will do the echo. Right now, since it's only a septal perforation, he won't.
Thank you.
Dr. Nagamatsu, would you like to change the angle and show us whether there is more tortuosity? I mean, you are working only in one angle. Would you do that? At the point of entry, there is a very tortuous. Would you see another orthogonal plane?
Yeah, it's better. It's better.
And can I see the tip injection?
Yes. I can see the tip injection from the areola side. Do you also have a areola side tip injection? If you have it, please show me areola side. Okay. So you did an aerial site also. Will you show me? Aerial side, maybe I think okay. Yeah, there are some bends, but maybe okay. So this is Shion. Yes. Yeah. Maybe around there are 5 millimeter from the bifurcation site. Yeah, from the tip injection, maybe the exit of the LED site is a more distal one from the tip injection, but the wire is going into the more proximal part. From your tip injection, the root is a more proximal part, more distal part. Yeah, this one. Yeah, I thought that this is a more distal part.
Yeah, so this is, so I tried with this vessel, but we can see the very big belly part. Can you see?
Yes.
Yes, we can see.
Yeah. So there are very different get advance of this belly.
Okay. Anyway, it's better to continue your procedure. Yeah, to get the success.
And so finally get advances of procedure like this.
Okay.
And we easily compare with the previous channel. So this time I tried with handle separation. This is the current situation. So I use, this is a micro catheter and the silver wire. So that's why that I would like to use the IVAS guidance.
Yes, to see the entrance of to confirm the entrance of the CTO exit, entrance.
This is actually a same French. Yeah. This is same French. Yeah. Please get 2.5 button. Yes, again.
2.5. Tracking, middle tracking.
About
That level come back? Okay. Kapardi, we will come back to you once you finish the IVAS. Once you do the IVAS, we'll come back to you. Okay, you have to explain us the IVAS exactly. So we are going to Dr. Igarashi and see what he's doing.
Dr. Ganesh, as a general guidelines, a channel perforation, how do you usually manage it routinely, just for a beginner if you have to? What do you do with the channel perforation? Do you just neglect it and just go ahead, usually?
So this one, there is a leakage to the ventricular. So no treatment, just leave it. If there is no leakage in the ventricular, you should do the fenestration to the ventricular by using a 3-gram wire like Ultimate Pro 3 or Miracle 3-gram. And if you push the aneurysm into the RV site, you can make a fenestration. But there is already the leakage to the
It's already
ventricular.
leaking into the ventricle,
So
that one.
so leave
If it doesn't, you break it.
Just observation.
Okay, Raghu, can you hear us? Raghu?
Dr. Igarashi? Dr. Igarashi?
We are with you.
Okay, can you tell us what you have done since we left you?
Dr. Igarashi? Okay, sorry.
Yeah, because I will let Dr. Igarashi work on this, because we are the critical stage for the case. So what we did was, we took a 1.5 balloon followed by a 2.0 balloon, and then we tried to put a stent across into the LED. But what Dr. Igarashi choice was put a 2.25 stent, but unfortunately we did not have it on the right. So we had chosen a 2.5 into 48 millimeter stent to cover the entire camera. The philosophy of Dr. Igarashi is not to put a very long stent and put a full metal jacket in this patient, especially because the vessel size is smaller.
That's philosophy, not only me. Everyone.
But anyone with the kind of
But before putting the stent, did you do an IVAS, Raghu? Dr. Igarashi performed an IVAS to see whether it's a diffuse disease or?
we did do an island down there again. No. We did only a contralateral angle and then we could assess the size of the length of the lesion. So we tried to deploy that stent at a very low pressure. Then approximately we are more dilating to 8. So generally we deployed at around 6 or 8 and nominal with a 2.5 stent.
Okay, 2.25, that is not available. Very
We had tried
So, okay, Dr. Igarashi, I just only saw at the puncture point of the LED CTO site. So, is there some special feeling? Oh.
How this is almost just covered all by 1%. Yeah. Additional setting is necessary. Yes.
Raghu, I have a question. Raghu, I have a question for Dr. Igarashi. Raghu, can you ask Dr. Igarashi a question? From the inflow of the stent to the exit of the stent, all the septals we can't see at all. We see the septal up and we see the blush out after the exit of the stent. So we lost a good amount of septals. Is it a temporary thing and it will come back? Is it stent dependent? Or did your wire go through subintima and come through the a true lumen? Why did we lose the septals? I'm talking about the blush. The entire 48 millimeters, we don't see the septals coming out at all. Maybe faint in the midst of the stent.
Yeah. So, before the stent implantation, maybe you did a balloon dilatation. So, we want to see the cine after the balloon dilatation before the stent. Are there any septal channels? Yeah, this one.
Oh, you didn't have a picture.
No picture.
Okay. No, they did.
Yeah.
There were.
Okay. Maybe only
Yeah, there was only one.
one.
They were deficient even earlier, but one septal was seen.
Yeah.
Okay.
Yeah, after stenting, there was a very small image of that's one septal.
Dr. Igarashi feels that it is not necessary to protect.
Okay, additional setting is necessary. I want to cover between proximal landing boundaries between the Brana channel and the Zeta branch. And then I will check I was finding in this current situation. Please give me I was. And I want to check distance landing. Yeah.
Okay, while you're doing the IVAS, Raghu, we are just going back to the other lab. You continue doing the IVAS, we'll come back to you.
Yes.
There is a interesting thing happening in the other lab. Chalo, switch karo. Switch, you're sleeping, switch. Dr. Kapardi, we are back with you. Dr. Nagamatsu, can you hear us? Dr. Nagamatsu, can you show us the IVAS?
I can hear. Okay.
Show us the IBUS.
So I started the IVAS from a diagonal. Okay. And I'm pretty sure the last level. Yes, last level. So So I searched on the right diagram branch, and as I checked the IVAS, they're using the volcano, evil eye.
Yes, yes.
And can you see the IVAS?
Yes, yes, we can see it.
And we can see the from the, yeah, we can see the from the line.
Yes, yes. Yeah, we can see it.
Okay.
Yeah, 9 o'clock, there is a LED. So you are pulling back from the diagonal.
Can you just freeze here? Please freeze here. Go step by step, one step ahead. Step by step. Freeze, please. Freeze. So we want to see you. There are two vessels there.
Yes, yes.
Kapardi, we want to understand the IVA step by step. Kapardi, yes.
Yes, yes, 9 o'clock.
9 o'clock, yes,
9
okay.
o'clock. Yes, yes.
That is the entry point. No, this is the entry point. And this, I already checked the angiogram of checking at that level. You can appreciate flow. Yes,
Okay.
this nipple is the entry point.
Oh,
So anyway, the once insertion on the wire, so I'll check again. Simultaneously by this IVAS.
so from the IBUS image, can you identify the nipple image or the some yeah, blood floating in the CTO region? Difficult. Okay, okay.
Yeah, very difficult. That's why we can see the very good lumen. And just frontal part of the head part. So that's very difficult. This is where is the nipple. But might be that this position is very close to the nipple.
Kapardi, for the sake of the audience, can you show us this case and IVAS guided penetration? Is he going to do the IVAS guided probing?
Yes, yeah, this is the same thing.
Okay, go ahead, please.
Yeah.
HDR.
Yes, yes.
So you're taking a fine cross with XTR straight away? Okay.
So that's why I choose fine cross. So I direct simultaneously.
Can you increase the size of the IVAS?
The fine cross catheter as well as IVAS.
Okay.
It won't accommodate both there in IVAS.
So guide catheter is a 7 French, 8 French. Guiding is 8 French. 7. That's fine. Yeah. If we use 8 French, Corsair and the IBUS, but the 7 French, Corsair and the fine course.
This is the best way, I think.
डॉक्टर की इमेज छोटा करो, IVAS को बड़ा करो.
Okay.
Now he is shaping the wire.
Yeah, we can see the your wire.
Wait, Kapardi, because
Okay. Yeah, you made a second curvature. Okay.
Kapardi, I want to see, just hold on, I want to see the IVAS and the angio
Yes.
by the side. Yes,
Yes. Yeah, it's better.
Okay.
Yeah. That's better.
okay.
This is the guiding of fluoro and is correlating IVAS as well penetration. IVAS also is simultaneous real-time IVAS and real-time fluoro. You want to demonstrate the penetration into the blind scan. And that's why I choose
So can somebody describe, there is a wire we see at around 9 o'clock, 6 o'clock rather now.
the side branch is IVAS. With the fine cross support, we give the HDR 20 to the nipple, and you can see I was also.
Oh, the wire is getting into the distal part. Oh,
Yeah, now you can see the entry point of the wire.
IVAS needs to be pushed into a little bit.
yeah.
You need to push the IVAS a little bit.
Yes, he's checking the same. Yes, he's checking. So he's pushing the IVA.
Yeah.
Okay, and maybe the depth, maximum depth is needed to see the depth. Maybe the maximum depth is needed to see the LED. This is maximum?
How the wire is entering into this one gap.
No, you need to push the IVAS.
Yes.
Anyway, you already crossed.
Yes. The wire is getting into the lumen, but we can't clearly see the IBUS image. Yeah, maybe okay. But we want to see, but it's very difficult to see it. It is the maximum depth. Depth is maximum. Okay.
Here, the better profile IVAS would be, what type of IVAS will you use here? Because
Usually, we use the Navi focus thermo IBUS. Thermo IBUS is a more low profile. But this IGRA is 20 megahertz, so it's better to see the more distal one. And maybe the IBUS wire location is, I think, okay. It's not clearly seen it because of the heart rate, heart motion. But maybe the wire is getting into the, maybe the intima close to the, near to the carina side. Dr. Nagamatsu, so the wire is maybe inside the intima from the IBUS image? Yeah, maybe, I think, yeah. From the carina side, but still, it may be.
it's moving in the same.
Yeah. That is, I think, the vein. Coronary vein is seen in the at 12 o'clock.
So there is a vessel you see at 12 o'clock, and there is a vessel you see at 9 o'clock. So the vessel which you see at 12 o'clock is not in continuation with the diagonal. Okay, and the vessel that you see at 9 o'clock was in continuation with the diagonal. So that has to be LED. And the
Yes,
other one is vein? It's
Yeah, I think so, vein. It's a vein. Yeah. So you already advanced the micro, fine close into the CTO region. Okay. Yeah, in this situation, maybe the IBUS is some disturbance. Oh, no. But you already made a hole, so maybe it's easy to advance again. You already made it. Yeah, it's better.
So he encountered resistance, and when he applied pressure, the whole thing jumped into the diagonal.
Yes. So he changed the wire into the more stiffer one. Yeah, I agree. So what is the next wire? Ultimate Pro 3. Yes. Yes. So maybe the route isn't clear. So that's why if the route is clear, we usually choose the Gaia. But this one, the CTO route isn't clear in the middle part of the CTO. So that's why he chose the Ultimate Pro 3. Is that right?
So So what Dr. Okamura is saying for the audience is the ultimate brothers he has chosen as the next wire because you don't know the route, you don't know which side to go. So the chances of a coated wire to penetrate would be better than what the XTR was doing.
Yes, yes.
So it will retain the property of an XTR, but the penetration force will be more.
Yes, yes. If we use a Gaia or conquest, maybe there is a risk of the perforation.
Right.
So that's why he chose.
So
Yeah.
now is we already get the integrated system. So I know about the operation. So you know this is the intermediate wire, not the part.
So this is quite a common thing. The moment you take the wire to enter into the LED, the IVUS comes back.
Yes, yes. Because it is a disturbance of the microcatheter.
That is why you lose the image. Both the times it happened the same thing. With the previous wire also the IVUS moved back. This time also the IVUS moved back. So hence the profile of an IVUS is important.
Yes, yes, yes. I agree. And can I say how we need to project the gap?
Yeah, the direction of the wire is okay.
Why you show the wire? You know
Yes.
all right?
Yeah,
Yes,
yeah.
now we can see, but exactly at the time of penetration, the IVUS moved back.
Yeah, so maybe that is a problem. So, yeah, if you push it, maybe the IVUS is kicking back. Yeah, in Japan we can use Navifocus. It's a very small one. But it's okay.
So you have reached the spot where you encountered resistance.
Hopefully. Yeah, but I feel the resistance here. Here. Still getting resistance. Yes.
Kaparji, can you show his hand movement? What he is doing with this wire?
Please focus.
Can you focus
Yeah.
on his hand? Because IVUS is of no use right now for us. Is he spinning it? Is it pushing it?
Yeah, maybe this kind of situation, yeah, this kind of rotation is needed.
Exactly. Yeah, so the very easy way to get advanced is by wire to the more exercise.
No. Keep the angio also. Hello, show us the angio too. Both hand and angio. Yes. Don't move the frame now.
Yes. No need of the just now the IVUS.
We don't need the IVUS anymore. Remove the IVUS. Just the fluoro and the hand. Yes.
Yeah. Yes, yes. I think that the next step is you should advance the microcatheter into the CTO region. And the important point is maybe the Corsair might be better to get enough backup support.
Kaparti, the suggestion is, can you take the microcatheter to the point of entry of CTO to get more strength?
Yes, it's
Yes,
better.
he's taken it now. Yeah. Yes.
Very hard. So I need more stiff.
Oh. Yeah, Gaia is a one choice because you already advanced almost a half. The another, so Dr. Nagamatsu, the microcatheter cannot be inserted. Microcatheter cannot. Okay. Another choice is.
It's microcatheter backbone again.
Yeah, yes. Another choice is Corsair.
But automatically get back okay. But very easy take this guy right here. When extend the microcatheter.
Yeah, it's better. change the microcatheter in the Corsair is the another choice to get the big backup support.
Yeah, but might be automatically think of this guide.
Okay.
This guide wire. And so one think of this guide wire, and so usually using the polymer capacitor. So we describe the sometimes the insertion of virus and the polymer capacitor.
Yeah, a little bit advanced. So maybe if you, around there or around here, maybe it's time to start the retrograde approach because you already have a retrograde. You want to, you want to.
Also, this time I can get advanced balloon. I would like to get advanced a little bit more.
Okay.
He's not confident of advancing the balloon, so he wants to get the wire more in. Yeah.
Maybe the fine cross cannot be inserted more. So that's why he wanted to advance more.
1.0 or 1.2.
Dr. Ganesh, I have a question. Why is he still keeping the IVUS there? Because that's obstructing his free movement of the wire. Is there any advantage of keeping the IVUS?
No, there is no need actually. There is no need.
Yeah, so. Okay.
No need, no, this time we don't need that. But due to this I was cutting that.
It's advanced.
Yeah, advanced.
And that's why so I make still the insertion of this I was, this I was cutting there. Wow.
Yeah, almost it's a good position.
Would you like to take your fine cross a little bit in now?
Can you,
I try again and again.
fine cross? Fine cross can be inserted. If it is okay, maybe you can advance the balloon.
Kapardi, there is a question. Why don't you remove the IVUS? Is it not? Kapardi, why don't you remove the IVUS? Okay. So, Dr. Kane, he answered the question.
I got it. Yeah.
Okay, so this time I try to activate the vibration. Okay, try the insertion of the balloon. Okay.
While you're going to take in a balloon, quickly for a minute we go to the other lab, just to get a summary. Other lab.
Oh. But maybe you already
Go to the other lab.
made the hole.
Switch to the other lab.
Yeah. You can recover it.
Dr. Igarashi, we are back with you. Dr. Igarashi. Yeah, please sum up your case.
Okay, all procedures finished. Yes. Please walk to just before implementation of second step. Okay, okay, all right. Which I was finding and the session is related to proximal part of the city region. Can you see? Staining is there. This stain is between diagonal branch and the third branch. And so we cover by 2.75 and then stain, and then this one, like this. And after that, I was finding some part is under spectrum and not so round shape because of calcium. So I tried additional non-compliant balloon, high pressure balloon, 2.5 until 20 funny atmosphere, and lumen size is not so bad. So I decided no additional balloon.
I think we should go to the other lab. This is interesting.
Expanded largely. And so vessel will come.
Dr. Igarashi, we'll have to leave you now because we are short of time. Dr. Igarashi, we'll have to leave you now. Okay, thank you very much. We will see you with more. Okay,
nice.
okay, beautiful. So, thank you so
You
much.
can see the septal appearing now.
Switch.
Dr. Ganesh, you could see the septal appearing now in the final shot.
Yeah. Dr. Nagamatsu. Dr. Nagamatsu?
Yes.
We are back with you.
Yes,
What is this wire now? We will be there with you for next 5 minutes. We are there with you for another 5 minutes. Which wire is this now?
So the UB3.
UB3? A new one? Or the same one?
Removing the fine cross.
Tell me, Kapardi, why did the wire come out that time? It was because of the pressure? You applied force and...
And no. When you are removing the IVAS, inadvertently, they are going and it came out. Friction. I check the IVAS again. Friction.
No, we still didn't understand. Why did the wire come out? Why did the wire come out?
Yeah, I don't know.
When you are removing the IVAS,
Doctor-
because of friction,
Okay.
fine cross came out. Yeah, of course, they can reintroduce the fine cross and IVAS. And then the fine cross removed and IVAS catheter was removed. And this I, of course, was reaching the distal cap. That we have done. Of course, I checked the IVAS again. And the crucial is that let's checking the IVAS on architecture.
Yeah, we can see the IVAS. So please pray
Show us
or
the angio picture also by the side. Angio by the side, okay.
Simultaneously, IVAS and angio picture. By the friction with the last
Yes, we got it.
That's the story. Please keep there. Please keep. And we another form. Okay. And I will show the last one. Okay. And please stop with the free and when
Yeah.
the NAV.
we want to see maybe the more distal part.
And please go. Yeah,
Distal part. Yeah. Yeah, this one. More distal. More distal. Because this is 9 o'clock. Maybe the area. Yes. Here, from here. Okay. So maybe from this image, wire is in the vessel. It's very difficult to see the intima or subintima, but maybe okay.
Maybe actual closure part is okay. And so now I try to open by balloon for the reverse part.
Okay.
You are backing out, your guide is backing out. when you're-
Yes. Yeah. Difficult. Yeah. Anchoring is needed. Difficult anchoring.
Before we go out, we have another 1 minute. Would you like to take a retrograde injection?
Yeah, it's better. It's better to see. Dr. Nagamatsu, it's better to see from the retrograde tip injection.
But this question is not correct, I think, no? So much when you get there, advances how you can space. I don't know. No, it looks more of intimate one. Really? Okay, please take a listen. Okay, so
Dr. Naga, Dr. Nagamatsu, we don't have enough time, so we want to see the tip injection. We want to see the tip injection from Corsair retrogradely, where the antigrade wire is. Yes, yes. Yes, yes, we can see it. All here. Yeah, so it is better to, how about the aerial? This is maybe the aeriocranial. Yes, yes.
In 1 minute, we are going to close.
Yes. Yeah, yeah, three picture is better because, yeah, here. Okay. Aeriocranial is, yes, okay. Yeah, yeah. This is a perpendicular direction. Yeah, wire is just.
So we will have to go off now. Dr. Nagamatsu we will have to go off now. Excellent work. A big clap.
Okay, okay.
Yeah. So before closing this session, the fundamental question is, should we have started antigrade?
Yeah. Maybe for us Japanese, maybe the 30% doctors will directly go to the retrograde approach, but the 90% of doctors, Japanese doctor, will do the antigrade first.
Yes.
In this case.
Okay. So we have closed this session. Thank you, commentators. And